I would like to introduce Emily Trittschuh. She's a clinical neuropsychologist and the Associate Director of Education and Evaluation with the VA Puget Sound Healthcare System's Geriatric Research, Education, and Clinical Center, known as GRECC. She's also a professor in the Department of Psychiatry and Behavioral Sciences at UW School of Medicine, and she has specialized in neurodegenerative disease and geriatrics throughout her career. She's particularly interested in strategies to promote brain health during aging and has developed psychoeducation programming and education materials towards this goal. Since joining the VA, she's developed an additional and complementary interest in the care of older veterans with PTSD and cognitive concerns. So I think you can see she has tremendous expertise to share with us on brain health and aging, dementia prevention. Welcome, Dr. Trittschuh.
Thank you so much for having me. I appreciate the opportunity to record this talk on brain health and aging and dementia prevention. I always want to start off with any disclosures if I had them. I do not. I have no financial disclosures. I would like to emphasize, though, that the views and opinions in this presentation are my own and they should not be taken and do not necessarily reflect official policy of the U.S. Department of Veterans Affairs or the University of Washington. All right, let's think about cognition and aging and what is mentation. In this series, we've had a number of presentations that focused on mentation, but I always like to bring it back to this 4Ms framework, where we have what matters at the top, mobility medications, and then essentially holding this up as mentation. Mentation can be characterized by both cognition and mental health, and these can interact in dynamic and complex ways. At the end of it all, though, the brain is what supports these functions. And I think at this point, you all are well aware that while some changes may be typical for aging, others can indicate pathological change. And so we're focusing on mentation. When we think about brain health and aging, unfortunately, it's often from more of a disease prevention viewpoint. The scientific research community has that disease-centric approach. And so any kinds of guidance typically comes in that sort of framework. So as I talk and review some of this information, it will be coming often from that scientific research perspective of dementia prevention. But please think about how when you work with, real people, that you'll flip it and approach your care using an age-friendly approach to take those disease-centric recommendations and make them into more proactive, person-centric recommendations. Keeping in mind, of course, that people want to live long, but with their independence. Research on longevity points to certain behaviors as being conducive to longevity. But if we're not looking at health, independence, and quality of life, that's not necessarily what people are looking for. So maintaining independence is a top goal for most. Keeping the brain healthy as we get older is very critical. Alas, this is in the context of an aging brain. There are many things that are challenging and seem inevitable. Cellular molecular changes with aging, metabolic changes. There are changes to nerve cells, DNA cell structure, midlife or later midlife. There is sometimes major fluctuations in the sex hormones, those natural repair systems of the body that also, of course, affect the brain are affected in aging as well. And even the immune system goes through some adjustments. And the DNA damage and changes to telomeres can be challenging as well. So then that leads us to think, well, gosh, how in the world are we going to get there? Can we cure dementia? At least right now, unfortunately, the answer is no. We don't have even any really great therapeutics. There's some cool new drugs that can actually remove amyloid from the brain, which is one of those components of Alzheimer's, the most common form of cause of late life dementia. But thus far, it's not actually resulting in cognitive improvements. So that leaves us in a tough spot. If we still don't understand how or why people get dementia, maybe why some people develop it and others don't, kind of in a tough position. It's important to really think about reserve and resilience. These are things that we want to build over the lifespan to lower the risk of developing dementia. So, in terms of approaches to dementia prevention, there are top risk factors. And I'll tell you what, the first one, age. We can't change that. And we can't change our genetics. So always trying to keep that focus on modifiable risk factors. Uh, a risk factor is something that increases one's risk of developing a condition. But remember, having a risk factor does not necessarily mean you'll develop a condition. That's different than, say, a genetic mutation or something like that. Um, Let's see. So I think when working with the folks that come in for care, the challenge as a provider is where to help them find reputable information, and frankly, even for ourselves to find reputable information, both as providers and as consumers. Personally, I do try to start with the science, and it requires our ability to read it critically because even well-regarded published science has certain, I don't want to call them flaws, but appreciations of limitations can be important. When I'm looking for reputable information, I often try to find either Cochrane reviews or other commission type publications that are in like respectable peer-reviewed journals. Uh, so, for instance, before this talk, I did a quick review of Cochrane reviews the past 2 years and really didn't find any that had found sufficient support for a few different things, such as a prognostic model for middle-aged adults for predicting their subsequent dementia, or even, say, for anticholinergic deprescribing interventions that were done to see if that would reduce the risk of cognitive decline or dementia in older adults. Now, when a Cochrane review doesn't find sufficient evidence and support for, it doesn't necessarily mean that those things were bad for people, but they have a very high bar, and that's important to consider. And I do go to these types of sources as a good first pass because I don't know about you, it's a rare clinician who has time to comb PubMed constantly. And then, frankly, even then, if you find one positive study or there's something that's highlighted in the press, it's rarely generalizable to the extent that they make it seem like it is. I also find it useful to go to the Lancet Commission in certain areas for initial guidance. Let me tell you a little bit more there. What is a Lancet Commission? It's a multidisciplinary international collaboration that aims to address some sort of pressing health issue through scientific review, inquiry, and response. When they put together a commission, they pull for experts and advocates from various sectors and disciplines, and these folks work together for 2 to 3 years. They then, their work culminates in a report that's published in the Lancet. If you're not familiar with the Lancet, it's a highly respected scientific journal. The commission reports are a little different from your typical single study research publication in that they actually go a step further than compiling the research. They often include recommendations for stakeholders and may even put in calls for change, advocacy of sorts. So, this here is the Dementia Prevention, Intervention, and Care report from the Lancet Commission that was published in 2020. It was pretty amazing when it was published, terrific work. And I'm going to review, there's this one, and then there's a follow-up article that I'm going to review in a little bit more detail. And when they do these, I just want to emphasize that they do look at, they prioritize, I should say, certain types of research, systematic reviews, meta-analyses, and then they additionally try to triangulate findings from certain specific studies. And they did it to figure out, to try to identify how physical and cognitive reserve develop and how reductions in vascular damage in particular can contribute to a reduction in new cases of dementia. I know right now this figure on the right is quite small. I'm going to just at the moment highlight the features that were super exciting when this came out in 2020. You if you look here, I'm going to try to use my mouse here and see if this will show up for you all. You can see down at the bottom here that risk unknown 60%. I want to emphasize much of this could be due to genetic associations or different genetic combinations. However, they were able to calculate population attributable factors, PAFs, which support the statement that 45%, 40%, excuse me, this up here that I'm circling, of the dementia risk is potentially modifiable. Now, again, the figure is small. You can see here I'm trying to circle around smoking. There's traumatic brain injury here. Those things felt pretty well known at the time as being risk factors, right? You should stop smoking, try to avoid traumatic brain injury, fight obesity. But there were other things that were more surprising. For instance, up here, hearing loss in middle age. Or there were other things that were exciting because it was really providing stronger support for interventions that we had already hoped were meaningful, like get physically active down here, as well as staying socially connected, avoiding social isolation. So these were pretty exciting. For the rest of the presentation, though, here, I'm going to jump ahead. I'm going to focus on the follow-up article. So I have a QR code here. This is the 2024 report of the Lancet Commission. And you might notice now that it says the Lancet Standing Commission. It is now an ongoing commission, and they published their first update since 2020, just this past July in 2024. With their new meta-analyses and incorporating interim significant scientific findings, they conclude that a life course perspective that incorporates the 14 risk factors that they've identified could theoretically prevent nearly half of dementias. Before I move on to talking about risk factors in particular, I do want to highlight some caveats that they actually acknowledge. First, I'm sure you've heard this phrase, association is not causation. So a statistical relationship does not mean that there has to be a direct causal relationship. Some of these factors are very complicated, and in particularly, they're complicated in their relationship to dementia incidence. Also, the potential for demonstrable reduction in dementia incidence is probably higher in countries with lower middle incomes, and among those minoritized populations or lower socioeconomic groups. There's more potential for more impact in those. Here is the updated figure. Again, you're like, gosh, that's really small, Emily, but don't worry, I'm going to focus on some of the portions here. Keep in mind that reduced cases of dementia can equate to greater longevity. But one thing I think that's nice about looking at dementia versus just mortality is that it does seem like if you're preventing or avoiding dementia, that would result in a greater proportion of one's life lived in what I think most of us would describe as a good quality, at least physically and mentally, that would be allowing us to do the what matters of those four M's. So if you notice, 45% of the risk is potentially modifiable in this updated 2024 article. Now, not the whole story, but it's pretty important. Okay, let's talk just really quickly about the early life education piece here. I want to emphasize this is 5% seems to be set. The stage is set for it in early life with formal education. But it's not just simple years of education. Educational attainment and quality of education are important as well. And it does go, keep in mind, this little green line goes all the way along. So we keep acquiring knowledge and experience throughout our lives. So that's an important thing to consider is this should not really ever stop. Okay, so for instance, in midlife, cognitively stimulating jobs might be key. And you can imagine how things kind of compound, hopefully positively, over time. So there's a lot of research out there that has tried to look at cognitive stimulation in later life. And keep in mind, it's probably pretty hard to find significant effects because they're less likely to be as strong as these early influences, right? So if it's a smaller dosage and for a shorter period of time here in later life, it would be harder to identify as statistically significant. All right. All right, let's talk about midlife because 30% of the 45% is here, if we see. And then here's a blown up view of it a little bit. Hearing loss is at the very top here. When it appeared among the risk factors in the original 2020 paper, I told you it caused some surprise. It's definitely an example of a strong associative finding rather than some specific known causal relationship. When they looked at a high quality meta analysis, they found a hazard ratio of 1.37. That's actually probably even conservative since the meta analyses included people who were actually treating their hearing loss with hearing aids. There is additional research out there, studies that have suggested that those who use hearing aids versus those who do not have lower dementia risk. And studies that have shown that worsening hearing loss, especially when untreated, is associated with increased dementia risk. Also, the longer in your life that you're exposed to hearing loss is also has associations with increased risk as well. Okay, there are a few other factors here like high LDL cholesterol, obesity, diabetes, hypertension, smoking, excessive alcohol. I want to say these are all important and complex risk factors. They go, beyond sort of the cardio and cerebrovascular risks they hold. I'll hit on some of them a little bit more later, just some of the foundational research for them later in the talk. But I'm kind of lumping them together right now because, at least from my perspective, in primary care settings, they're typically well addressed. And so it's less about what people can do for themselves and associating with the what matters. It's usually done more in a medical. If you want to read more about the Lancet's support for the percentages they assigned here and how these came out, I highly recommend going and reading that Lancet article directly. Okay, TBI, traumatic brain injury, is still here at 3% in midlife. A challenging thing about traumatic brain injury is like no one ever says, oh, yeah, I want a brain injury. Maybe what would be useful here is just to think about what are the risk factors. Younger folks, males, are more likely to experience traumatic brain injury. In lower and middle income countries, it's often commonly due to traffic accidents. But unfortunately, in higher and sorry, not unfortunately, but interestingly, in higher income countries, traumatic brain injury is often due to falls or violence, and alcohol is often contributory in these situations. Uh, just a little note for the Lancet Commission's work. They really included sort of the full definition of traumatic brain injury, not necessarily including mild TBI or concussion. The research there is challenging. There's some great longitudinal studies underway. And there's also research suggesting that repeated mild TBI is a risk factor, but it didn't reach the level of including it in this report. Let's see. In terms of, well, I think that's what I'll do cover here. Let me just move to this next slide. Okay. Again, back to these midlife factors. I wanted to mention depression. Depression is an interesting factor, and it's at 3% here because it's actually likely what's called a bidirectional risk factor. Depression, that means basically that depression can both be an early symptom of dementia as well as being a risk factor for its development. That makes it trickier for us as clinicians. But regardless, addressing any depression, especially if we can identify it early, is what's important. For the Lancet 7 studies that they included for meta-analyses, they found a relative risk of 2.25 looking at depression. I found one of the studies particularly interesting. It was a Swedish twin study, and it found no difference between identical and non-identical twins, which suggests that genetics and early life exposures are not the likely explanation for this effect. So you might ask, well, what could the mechanisms be overall in general for depression? Is it that folks who experience depression may have some reduced self-care, maybe less social contact, less physical activity? There's also biological factors such as oversecretion of cortisol that could lead to hippocampal atrophy and even inflammatory responses. I bet you're asking yourself, well, will treatment of depression mitigate the risk? And that's not coming out as just the strongest factor yet. It's not entirely clear. More good studies need to happen, but of the good studies that are out there, it really does suggest that the answer might be yes. And there's definitely no studies showing that treating depression should cause, or at least with, evidence-based therapies would cause harm. Okay, I want to hit on physical activity here. It's right in the middle at 2%. Like depression, the 2020 Lancet Commission found this to be a likely bidirectional factor. If physical activity declines later in life, it can be a symptom of prodromal early dementia. Studying exercise is one of the hardest. The most measurable effects are found in individuals who have gone from extremely sedentary to very active. as you might imagine. And for those who are active their entire lives versus those who are sedentary their entire lives, there is no guidance in the Lancet Commission's article for what type of exercise to do or how long. Uh, However, you can look a lot at mortality literature. And at the end of the day, the challenge is you actually have to do a fair amount of exercise. I'll come back to exercise a little bit later. Okay. Oh, wait. 1 second. Nope, that was it. I'm having a slide problem here. Okay. So one thing I want to mention with this little slightly smaller midlife figure is I want to emphasize that all of these yellows, these yellow lines, they continue into later life. So please don't forget about them if someone is, say, 70 versus, say, 60. We want to talk about those and address them at all points. But talking about late life, you can see here 5% attributable to social isolation. The challenge is social isolation can be defined in many different ways. Definitions are variable across studies. The UK Biobank data is an example of a terrific longitudinal large study defines being socially isolated as for a person who would meet, say, two of three of these criteria. The first criteria being living alone, another one being seeing family or friends less than one time a month, and then the last criteria being participating in no weekly group activities. And that's a pretty high relative risk there, essentially a range of 1.18 to 1.57. Now, the range there is probably that it exists at that much is due to the differences in duration of follow-up. And again, a little bidirectional factor there. Sometimes late life social isolation can be a symptom of early prodromal dementia. I want to emphasize loneliness is often linked to social isolation, but it is different. It is also associated with increased dementia risk, and it actually can really occur in individuals completely independently of social contact. So think about it. It's not unusual that someone may be a social butterfly, but inside is feeling very lonely and also have that increased dementia risk. So it's important to ask about both. The same way that when you ask about depression, you also want to ask about suicidal ideation because they, while often linked, can occur independently. A challenge in looking at interventions for social isolation is that there's just a bazillion different options out there, right? What's consistently found is that efforts to improve and reduce social connectedness and reduce isolation don't seem to ever hurt anybody. The next factor here is air pollution at 3%. I'm not going to go into detail here with this is because this is largely a global community population-based issue. And it affects different folks very disproportionately. And as a care provider and trying to provide you with information that you can do with the people you work with, it's not really something that we can typically help people modify for themselves. The last thing here is visual loss, and it's at 2%. I'd like to say that this is actually referring specifically to untreated vision loss. Globally, there's a prevalence of avoidable vision loss and blindness in folks age 50 and older that's estimated at about 12.6%. And those estimates are much greater in lower and middle income countries versus higher income countries. So this finding for visual loss in late life is really based on a lot of research that looks at basically correcting situations where people say have untreated glaucoma or diabetic retinopathy. And, the literature supports this increased dementia risk in those, say, with cataracts versus those who either never had cataracts or had cataract surgery. Because this one was new in 2024, the authors of the commission report emphasized that they included it, even though it's at 2%, because they felt it was important, given that the treatment of vision loss, removing cataracts, giving medication for glaucoma is both effective in that it helps with the vision loss, but it's also cost effective. And so therefore they wanted to include it and they wanted to emphasize it as a great opportunity globally to reduce dementia incidence. Okay. Some of the key differences between 2020 to 2024, one that was pretty great, I thought, was that the potentially modifiable components went up from 40 to 45%. There was also a shift of a number of items like smoking, depression, physical inactivity, and diabetes from the later life segment to the midlife segment. You can take that as a positive or a negative, depending on when you know how old you are, how old your patient is, and when it can be initiated. But it is emphasizing that even more of these things matter in midlife than we thought. Uh, New in midlife is that high LDL cholesterol. That one seems like a no-brainer. New for later life was that addition of vision loss that I just mentioned. The early life percentage for education dropped down to 5% from 7. Not such a huge thing there, but maybe due, at least as was back then, increasing early education. So I think the thing I'd like to drive home here is it's important to try to address as many of these as possible. There are a lot of great multi-component studies out there that suggest that cognitive strength and aging relies on an overall healthy approach, not just doing one thing right. This is a figure from the Lancet 2024 article emphasizing different interactive risk factors and their likely slash potential mechanisms. I will not talk more all the way through this slide, but it's just here for your perusal. I do want to dig into the vision and hearing loss again, just a little bit more. There are a lot of reasons to think about the interrelations of vision and hearing loss and its effects on cognitive aging. There are reports on this connection of sensory cognitive performance and the increase in the strength of these associations as people get older. The typical age-related and vision changes that for some folks seem sort of inevitable do appear to adversely affect cognitive performance on things like what I do as a neuropsychologist, and they are documented risk factors for cognitive impairment, dementia, and a speedier progression. Again, these intervention studies, taking those cataracts out, wearing the hearing aids, having age-friendly environmental accommodations, having people train on how to work with people with vision or hearing loss, all have been shown to have positive effects on cognitive performance, dementia risk, and mitigating its progression. We also want to think about how these interact with other mechanisms that can either promote dementia development or mitigate that risk. Think about how loneliness, isolation, depression, reduced activity, and participation can all be sort of interactive. All right, so I had said I would hit on vascular disease, which basically is this high LDL, cholesterol, hypertension, atherosclerosis. I don't think I'm going to read over this in all detail. I think you're pretty aware of it, but I wanted to just give this older review that I thought was a nice coverage of the topic. With all of these, having diabetes or smoking can make things even, worse. Uh, I Oh no, sorry, I'm laughing at myself. I think I somehow have this as an animation when I didn't want it to be. So let me keep moving forward here. To talk actually for a moment about obesity, which was in our thing. And now what I have to do is hit this so that that'll show up. I wanted it to show up simultaneously. Obesity is highly related to our body's ability to use insulin and its metabolism as well as glucose metabolism. These things interact, and obesity is essentially a model for accelerated aging. It's associated with peripheral insulin resistance, decreased adiponectin levels, and unfortunately, just sort of an enhanced chronic inflammation. And then we actually see the opposite in what's sort of been termed as delayed aging or longevity. I wanted to include this older figure that just kind of tried to break out why obesity, which can often lead to diabetes, and here diabetes has mechanisms that it influences that in many different independent ways can affect brain pathology and dementia. I am afraid this little thing is not going to show up on time for all of my slides. I'll try to remember to double click as I move along. Okay, let's talk about excessive alcohol just as a moment. Um, it can be not as well addressed as it should be. Alcohol can be both a primary or a secondary cause of dementia. I think everybody kind of knows, oh yeah, long-term excessive drinking causes damage to the brain. We think of like an alcohol-related dementia or Wernicke-Korsakoff syndrome. But people forget sometimes is that drinking can increase risk of common types of dementia, such as Alzheimer's disease and vascular dementia. It also increases risk of stroke and heart disease independently. And then it's kind of important to address alcohol consumption with older adults that we work with. 2 to 10% abuse alcohol or are alcohol dependent. At-risk drinking has been found to be prevalent, about 15% of adults over 65. There's also negative potential, likely interactions between alcohol and the medications that people often take in later life. Then there's the simple fact that it messes with and helps promote other geriatric syndromes, delirium, falls, head injury. And it's not uncommon that I speak with an older veteran who is unaware that the what's considered moderate drinking is actually much lower in older adults than when they were younger. Okay, smoking. This one everybody knows, I think, that smoking is bad. This was an old, I guess it's not that old, it's about 10 years old now. This was a nice study that pulled together 37 high quality prospective cohort studies. And I included all these breakdowns here, not because, don't worry, I won't read them all to you, but because it really suggests that there's so many different points for intervention. Because while smokers have an increased risk of dementia, smoking cessation can decrease if when kept up long enough, can actually have their risk then decline to that of never smokers. So it's really true when people say it's never too late to quit smoking, it really isn't. They are also has found that current smoking has differential increased risk of Alzheimer's and those that are ApoE4 E4 negative versus those who have the higher risk allele of E4 positive. Also, there's some challenges with these studies. There is survival bias, and competing risk also reduce the risk of dementia from smoking at an extreme age. So I'm trying to think if anyone remembers who George Burns was. You know, he supposedly drank and smoked all the way, and he lived to over 100. There is some suggestion that once you live beyond a certain point, that this may not matter as much, but I'm not sure I really subscribe to that point of view. All right, mental health. Oh, see, I'm going to fight with my animations here. Apologies. Mental health conditions. If you remember that depression was there at 3% in midlife, early onset depression before age 65 years, as well as recurrent depressive episodes, are long-term risk factors for development of dementia. The challenge is that late onset depressive symptoms can be that feature. This is that bidirectional relationship, right, of a prodromal phase of dementia. There are more recent studies than this. Sorry, this is I should have edited this, but I did think it was a nice study done in 2012 that showed that long-term treatment with antidepressants actually can decrease that risk. I put here the post-traumatic stress disorder because I work specifically with veterans and there's a higher prevalence of PTSD among that population. And then a couple different strong studies that came out in 2010 suggested or found, I should say, that veterans with PTSD had double the risk of those without PTSD of developing dementia. For anyone that's got a little anxiety, which I may know a little bit about, it was actually really nice to see an impressive study out of Rotterdam that came out in 2014 that found that anxiety was actually not associated with risk of dementia or cognitive decline. Let's turn to that physical it says physical inactivity at 2%, but I like to couch it more in terms of physical activity. This particular article here from 2015 was looking at the 2008 physical activity guidelines, which recommends 75 vigorous or 150 moderate intensity minutes weekly, showing this dose response. And they did a pooled analysis of 6 prospective population-based studies. So you can see here that this is the J-shaped curve where no activity weekly is clearly bad. Oh, and by the way, I'm sorry, this was not a dementia study, but in particular, this was actually a mortality study. Uh, but useful when you think about the dose response here. So none is bad, and a little quickly gives you lots of benefits, right? And then there is a point where potentially one could do some harm for life expectancy if you kind of really go beyond their recommendations. But I got to tell you, 75 vigorous minutes or 150 moderate intensity minutes a week, that's doable, but that's a fair amount. That is not a low bar. This study here, published in 2014, looked at 47 cohorts overall, derived from a couple different previous systematic reviews. They did an updated database search, and then they put them all into the meta-analysis. They made sure that older adults that were in these studies were over 40 years old, in relatively good health, or had been sort of randomly selected. So this was not like a medical center population. When they looked at this, I think I'll just go for the overall effect, which is you can see here that physical activity in older adults reduced risk of dementia, because this line here at 1 is that crossover to increased dementia risk. There were some sensitivity analyses, and it did seem that in high quality studies, there were, sorry, they were finding that it could be up to an 18% reduction in the risk of dementia in the most high quality of the studies and those that had the largest samples. Okay. But you've probably all heard some of this information, and that is that when people try to conduct randomized control trials, RCTs, which are considered sort of the gold standard in research of looking at exercise programs for people without cognitive impairment over age 55, they are not finding that there are significant effects, or that what they're finding and trying to look at is whether this can improve cognition. However, if you look at the second to last bullet point here, there are no findings that it is bad for cognition, just to emphasize that. So it may be that a dosed sort of exercise program may be helpful for particular subgroups of people. It may be that the exercises needed to be more intense, but it also might be that incorporating physical activity needs to start at a younger age and basically be done continuously. Social interaction, that was on here in later life at 5%. There are so many studies that have found associations between brain health, aging, and social interaction. What's really challenging is how do you measure social interaction? It's often not the researchers measuring it, but people self-report. I wanted to include this longitudinal study from the Rush Memory and Aging Project that's out of Chicago, because they really specifically had lovely questions at baseline about people's social network size. They even did a structured clinical assessment to look at all these other areas. They were able to include things like being physically active or doing cognitively stimulating activities as covariates. And they found that even when participants died with severe levels of global disease pathology, their cognitive performance was still higher after controlling for all these other factors. So I thought that was just a particularly nice study to highlight. Okay, what else might you think of? This is what was in the Lancet Commission, and the things that I chose to highlight. But you might be thinking that there are other things. Is there anything that seems to be missing? Personally, I was like, where is sleep in all of this? Because I like sleep. It's tricky. Sleep has not been included with the Lancet Commission. However, I want to say that there is a lot of solid research out there that suggests that having too short of sleep, basically consistently getting less than 7 hours of sleep, especially in middle age, sort of in this, it's sort of the 50s and 60s, can increase the risk of developing dementia later in life. There's even the flip of that, which suggests that some people who have excessive sleep might actually have a greater risk of dementia. Although here's the potential for that bidirectional relationship. It's possible that those studies are picking up on early symptoms, as sleep being one of the earliest symptoms, the excessive sleep. There are studies that suggest that sleep quality, rather than just the amount of sleep, is a crucial role in whether dementia might develop. There's also lots of research out there that people with untreated sleep disorders, like sleep apnea, have increased risk of dementia. Also, for people that are experiencing sleep-related movement disorders like restless leg syndrome, those folks do seem to have an increased risk of all-cause dementia. Again, here's another one of those complicated factors that has a likely bidirectional relationship. Oh, I'm sorry. Let me go back for 1 second. This healthharvard.edu blog is a resource that I like. It seems to do a really nice job of taking the best research and putting it into layperson terms. And again, this is a personal recommendation, not one I'm saying as an employee. Okay, well, another thing, what about nutrition? Most of you, that didn't come out in the Lancet either, but think about it. They're looking at global mechanisms and risk factors. In terms of nutrition, the MIND diet pretty consistently comes out on top. That stands for Mediterranean Dash Intervention for Neurodegenerative Delay. Whew. You could probably just call it a Mediterranean diet. The DASH part of that is a diet that was developed to reduce sodium and processed foods, thinking about cerebral and cardiovascular risk factors. So it's kind of the combination of those that seems to be consistently showing good results. For this diet, basically, you want a higher intake of vegetables, fruits, nuts, legumes, unrefined grains. You want to bring in simple, unsaturated fats and keep those saturated fats down. Things like fish are very good, but trying to keep down dairy, meat, and poultry products. So I had just a couple findings here. There was a Cochrane review that was done that demonstrated quote unquote limited evidence, but it was all in the direction of being useful rather than bad. And when they found that a few studies that had done very strict reductions in fat intake, they actually found some evidence for reduction in cardiovascular events, breast cancer, and type 2 diabetes. So I just thought I would throw in, I stole this like little pictogram here from the Pacific Neuroscience Institute. I don't know anything about them, but I did think it was a nice representation of the components of the MIND diet. So you can see here, you got to pick things from healthy food groups of a certain amount and quantity within a day or week. And then they emphasize which food groups and items to try to limit. So I think one of the biggest challenges is sort of this flipping of our perspective, trying to provide information to the people we work with in a positive, proactive framework. And also, frankly, I don't know about you, but it's pretty hard to keep up with the latest news flash or fad or what news article sort of journalistic article grabs on to one side finding of one study and kind of blows it up. We Yeah, so I just think it's really tricky. So, for instance, omega-3 fatty acids were hugely in the news, and there's evidence that they might be good. But that alone, especially if you're thinking about not getting it from your diet, but from pill form, is probably not quite as strong of evidence. And then there's, oh, sorry, I should say, but the evidence for this is definitely better than, say, oh, I don't know, for coconut oil. And that was quite a fad probably about a decade ago. So I just have the following tips for talking to your patients with the people that come to you for care. And that is number one, be composed. The first time someone mentioned that coconut oil thing that they were giving a loved one, I think it was like 4 tablespoons straight up coconut oil daily, I did not have a poker face in my reaction to that. So try to keep yourself very neutral. You want to try to keep up with the literature, but you also, the scientific literature, but you really also need to pay attention to the popular press. I think it's useful to show, not just talk at people. Here I am just talking at you all, but as much as you can show people with graphs or figures, it's a lot easier for people to understand and to really sort of visualize what it might mean for them. Also, always be ready to help people, not necessarily tell them exactly where to look, but giving them guidance on how to identify if something is reputable or not. I also always tell people that if someone's making big claims and they're asking for big money, you should get suspicious, right? This supplement will prevent Alzheimer's disease, and it only costs $300 a week, right? That should be highly suspicious. That should be being prescribed and covered by Medicare, right? But then the challenge is that we don't want to squash hope. I want to go through this very quickly. It'll seem like a little like self-promotion, but just as a reminder, I work for the federal government. I can't make any money off of anything. I've been chairing this aging and cognition education work group, and it's a collaboration that we have been working to create educational products. So this is our current membership, just to give them a little credit. Our work group started actually 20 years ago as a dementia education work group. And then we reformulated ourselves. It's probably like 7 years ago as the Aging and Cognition and Education Work Group, because again, we wanted to have that positive, proactive approach. We have a pretty systematic method for developing our patient or sometimes provider facing education tools. And if anyone tuned in for my 3Ds frontline care talk, that was the beginning of this ADRD series about differentiating delirium, dementia, and depression, I highlighted our 3Ds guide back then. That's been highly popular. We also have this outpatient focused delirium reference guide. But what I think might be useful for this talk is our brain health and quality of life and aging booklet, as well as the newer clinician tips. So let me just go forward here. I'm going to mention these two a little bit more. Here are the topics that we hit on in this brain health and quality of life. I'd like to mention, though, that we started doing this before that very first Lancet report. And yet here you see a lot of what was in there we have on our product as well. So this is just a quick visual of what the pages look like. Of course, we're at the VA. We do emphasize mental health and post-traumatic stress disorder. I don't know if you know this, but the Veterans Crisis Line, dial 988, then press 1, is the same as the National Crisis Line. You just don't press 1 unless you are a veteran. So that works for others as well. Loneliness, physical activity, side effects, that vision and hearing. I'd like to think that we were somehow ahead of the game there of the Lancet Commission, but here we are. So the newer tool that we have is a brain health and aging worksheet. When we first started it, we were really off the mark. It was like an RX sheet, like people wanted providers to just tell them what to do and prescribe, say, exercise or you sleep better. We really, in our development process, wanted to make it more age friendly. We wanted to make it more proactive and more of a whole health approach, right? So it's really been shown time and time again that just telling people to do things doesn't work. We need to actually really connect the brain health activities and behavioral health modifications to what matters. So you saw just a second ago the front of the worksheet, but here's the back where you work collaboratively and interactively with folks to identify what matters to them because of those values. What brain health goals do they have? And then, frankly, we all need a multimodal approach. Have them pick what they think would help move them toward their goals. And then critically, we're there to help provide additional resources, but also this is still interactive. What resources can they identify? Okay, so I kind of just said these things right here. You review that checklist. I think what's really important is that you Invite them to share with you what's of interest to them, and always, always acknowledge the efforts that they're already doing, right? And when it comes to making goals, make them as, have you heard of SMART goals, right? Specific, measurable, attainable, realistic, and timely, right? We want to help them make SMART specific goals. So here, for instance, would be like what somebody might write out as their sort of what matters to them, what sort of brain health goals they have. They want to be both clear-headed and live as long as possible. And then here are those very specific SMART goals, right? Go to the senior center 1 time a week. Walk 15 minutes a day. Does everyone have to come up with 3? No. Come up with what works for the person that you're talking to. I will not read over all of this, but on the inside of the worksheets that we have, there are actually tips for providers for having conversations about healthy brain behaviors. And frankly, this was developed by a trainee with Dr. Christine Gould in Palo Alto with our group to use the psychology motivational interviewing skills to really help guide the conversation. So importantly, you try not to just ask yes, no questions. It's got to be open-ended. You want to have lots of affirmations, recognizing people's strengths. This is a way to establish rapport and also help build their own confidence that change is possible. We use reflections. We try to highlight positive change talk and even negative with the goal of sort of reducing negative change talk. And then always at the end, try to create a summary so that there's sort of this connected understanding of what's interesting to them and what their understanding is. Okay, thank you all for your attention. Um, these products are available if you're interested in any of them. They are free. All we ask is that you give us a mailing address, a quantity, and the population, kind of who it is that you are planning to use them with, so that we can support further printings if we need to. So the contact person for that is Julie Moore at va.gov. And then here are my 2 email addresses for work. I'm always happy for anyone to reach out, any curbsides. Um, yeah, so thank you so much as we all try to keep up to date with how to promote brain health and how to disseminate that information and motivate people towards positive change. Thank you very much.
Dr. Trittschuh, this was so helpful. And I just want to say one of the things that was outstanding was as I was kind of framing or thinking about a possible question, you'd then answer it. And so that was particularly helpful. An example is the making the distinction between social isolation and loneliness. I thought that was nice. I did want to mention also that in the last year and in the upcoming spring uh, geriatric healthcare series. We do have talks on several of these risk factors, including social isolation, hearing, social connection, and prescribing. And so if some of these risk factors are of interest to you, you might go to nwgwec.org and you can go to our healthcare lecture library and potentially find even more details about this. Another thing that I found helpful was what to say to patients who are not necessarily going to the research literature, but still have the questions. And so you gave some helpful information about how to address those. So thank you so much. This was great.
Thank you. I really appreciate this opportunity. And yes, I can't believe I missed that. Yes, everyone, check out the list for the spring series. There's some amazing talks in that list. Yes. Thank you.
Thanks.